This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Today, our subject of the podcast is concerning non-valvular AFib and stroke prevention. And in particularly, could the Watchman device eliminate the need for long-term anticoagulation? And with me today, I have a very special guest, a great friend of mine, Dr. Greg von Mering, who is Associate Professor of Cardiology at the University of Alabama at Birmingham. So Greg, thank you very much for accepting this invitation and for being here today with us.
Absolute pleasure. Thanks. I look forward to the conversation.
Great. Well, we know that AFib is the most common cardiac arrhythmia, and it affects millions of people with vast socioeconomic consequences because of its association with stroke. There are between 5 and 6 million adults in the U.S. with AFib, and it's projected to increase to 16 million in the next 30 years. The lifetime risk of AFib in men and women older than 40 years old is 1 in 4. That means, Greg, for you and I and all of our listeners today, the lifetime risk of us developing AFib is 1 in 4. So that's really quite a large number. We know that patients with AFib have a 5-fold increased risk of stroke. Systemic anticoagulation, of course, the therapy is highly effective, but it's difficult for many patients to sustain over time. This has led to development of alternative approaches such as the Watchman and the Watchman Flex device, particularly in patients that are at increased risk. So let's talk about protection against stroke. We know that warfarin works. As a matter of fact, the risk of a stroke is significantly reduced with warfarin to the order of maybe 1.5 to 2.5% of stroke versus a much higher percentage if you don't take anything or just aspirin. But Greg, can you tell us a little bit what are the problems with long-term anticoagulation with warfarin?
Well, we've used them and become comfortable with them as clinicians, and I think in a sense have had a false sense of security about their power to prevent stroke in AFib, and probably spend a lot of time overestimating our own ability to change that management course in an individual who presents with AFib and who we want to treat with an anticoagulant. And what I'm driving at with that is, as best as we can do as clinicians in our office, I think that everyone would admit that it would be hard to meet the bar of assuring compliance and avoiding complications of anticoagulants as we have done in large clinical trials. And when we look at the clinical trial data, it is dramatic in terms of its demonstration of a couple important points. Number one, no matter how carefully we administer NOACs, DOACs, or warfarin, we still face a floor of major bleeding complications that just can't seem to be overcome. And so in all of the big trials, both a large series of warfarin trials, we saw 3 to 3.5 or greater % of bleeding complications per year, no matter how vigorously that was monitored during the trial. And similarly, and actually much more surprising to me, in the NOAC trials, we saw a persistent 2 to as high as 3.5% bleeding complication rate per year for all of the major trials. We're talking about Rocket AF, Aristotle, Rely, and Engage AF, TIMI 48. Just again, this floor of bleeding that we cannot overcome. And there's no doubt, and we'll talk about this as we look at the trials that compare or that bring up the device intervention. We know that as we go out year by year, our patients are going to face that bleeding complication. Then on top of that bleeding issue, we have to add discontinuation rates. So we hope and expect our patients are going to comply with these drugs. But we know that with warfarin, though inexpensive, it's complex to use and requires great compliance and follow-up. And with the NOACs, though much simpler and without surveillance requirements, we know that their expense and the very fact that you have to take them every day and sometimes twice a day leads to compliance issues. And so, again, we as clinicians know about this theoretically and think about it on occasion with individual patients, but we don't really think about the actual rates of discontinuation. And if you look at the trials, they again describe in a very sternly educational way how difficult it is to get patients to comply. And so again, in the big NOAC trials, we saw between 23 and 24% and higher, up to 34% in the endoxaban trial, discontinuation rates at 1 year. And for warfarin, again, anywhere from 16 to about 30% discontinuation rates. So if they're not taking it, they're not protected. And then we have the issue of an event occurring as a result of discontinuation. So we have bleeding on the one hand if they comply. We have discontinuation and stroke complications if they don't comply. Now, on top of that, there's two other issues. This really becomes a fascinating, this whole discussion of why does anticoagulation have, why is it frail in terms of our approach to prevention of stroke and systemic embolization? It's a fascinating conversation that has both what we've just described, bleeding and discontinuation rates. But then if you look at warfarin, the complexity is even if you can get someone to comply, the challenge is to maintain them in this narrow therapeutic window. We know we have to maintain people somewhere between 2 and 4 to stay in a safe range. Lower than that, we see ischemic events. Higher than that, we see bleeding complication rates. And we know, again, from this great series of NOAC versus warfarin trials, that time and therapeutic range, the period of time that a patient is in that safe range, are much lower than any of us would think. So they're in the 55 to 65% range. Ironically, and this will become important with our discussion of PREVAIL, the second large randomized trial looking at Watchman versus warfarin, the time and therapeutic range was higher than any of these trials. It's very unique, and it'll become an important point, I think, when we talk about why the ischemic event rate for warfarin was so low in that particular trial. But in general, if we can get somewhere between 50 and 60%, we're lucky in terms of time in therapeutic range. One final point I want to make about this, and this is something that I think all of us see clinically, and that is when we have a little frail person come in, even if they don't meet criteria for reduced dosing with apixaban. So weight, age, renal function. If they don't have 2 of those exclusions and allow us to reduce the dose to 2.5 twice a day, for example, we see this tendency in broad practice, not necessarily in the cardiovascular physician group, but in the general practice group as well, to reduce the dose empirically to 2.5 twice a day, because we think that, well, it's probably a little safer and maybe it'll give them some protection. Well, in a very provocative retrospective study of over 8,000 patients, they were able to demonstrate that this tendency to go with an off-label reduced dose is associated with increased events and, ironically, does not reduce the bleeding substantially. So there's all of these factors that come into the effectiveness of using anticoagulants. They've been an amazing step over nothing or over aspirin, as we know. But there are complexities in administration and the complexities in compliance leave a lot of room for improvement. And so that, I think, is the motivation to look for a mechanical solution.
Well, that was a lot of information there, Greg, and you went kind of way fast forward. So I'm going to recap a little bit, and we'll talk about, what data that we have with Coumadin. Obviously, we have the problem with bleeding, and major bleed is in the order of 3.5%. And if you look at any bleed in all the studies, between 15 and 25%. So bleeding is a real factor. The other thing you mentioned, and we mentioned about the warfarin, is the difficulty about, having that therapeutic range where the INR is between 2 and 4. That we can accomplish only in about 60% of the patient. And this is like in clinical trials where we have the best condition. We have problem with adherence, and about 50% of the patient don't really take their medication, and or sometimes we have problem discontinuation rates is in the order of 20 to 25%. So that's the problem with the warfarin or Coumadin. It's inexpensive, but we have the bleed and the problem of therapeutic range. And now with addressing the NOAC, or the novel or the new oral anticoagulant, or you could describe them as the direct oral anticoagulants, either against factor 10 or antithrombin. But these are like the apixaban or Eliquis. These are the Xarelto or rivaroxaban or the Bigatran or Pradaxa. And obviously these novel anticoagulation, they really work. I mean, they can prevent stroke. You get a stroke rate, it's not to zero, but it's about 1.5%. The problem is there's still bleeding, as you mentioned. A bleed maybe a little bit lower than warfarin, but it's still about maybe 2% for apixaban, maybe a little higher, for Xarelto. But these really protect stroke, but it's still a problem with bleeding. So, and then obviously we're dealing, with patients that have to take medication, and you're dealing with patients with high risk. Of course, if you have low risk, and we could talk about that in a little bit about the CHADS-VASc and how we calculate the risk. If you're low risk and you miss some doses, it probably doesn't matter quite that much. But if you're high risk, CHADS-VASc score, greater than 2 or 3, if you miss some medication, you're not adhering to medication, then your risk of stroke is probably double. And if you have even a higher risk, like CHADS-VASc score 4 or greater, your risk is about 3 or 4 times if you don't take your medication, the way you need to. And if we look at maybe Medicare or insurance data, even with these newer drugs that have, that are well tolerated, the adherence is probably still just like 60 to 70%. It's really mind-boggling. And we're not very good about asking, our patient, are you taking your medication, regularly, or how are you taking it? It's very difficult to really kind of check on that.
It really is remarkable. And I just throw in there this discussion about the risk treatment paradox that's out there, that, we have a way to calculate risk, CHADS or CHADS-VASc score, but remarkably, no matter what that risk, as it increases from 0 to 9, we know that there's a ceiling of treatment when we look at broad swaths of patients nationally, that really very few times can we get above 50% of patients that are candidates for anticoagulation actually receiving it. So that's a physician's decision side where we think the risk is too high for all the reasons that we'll talk about, with left atrial appendage occlusion being an option, or for other reasons, again, patient unwillingness to participate. But even in those people that we would intellectually like to be on anticoagulation and might be candidates for it, we know we hit about a 50% achievement rate in getting people on it.
I know we've talked about it on previous podcasts, but could we maybe just kind of brush up a little bit on our CHADS-VASc score, Greg, and maybe if you could discuss also the has-bled score, which is, the risk of bleeding. So just to kind of, summarize a little bit some of the factors we'll look at, because it does matter. The patients with higher score have higher risk of stroke, as well as patients with higher has-bled score have higher risk of bleeding. And this becomes particularly important, this discussion, when we want to prevent stroke and prevent bleed, with a device like the Watchman.
Without a doubt. And so, the one of the great things about apps for your phone now is that we can all calculate these scores easily. And so I will tell you that when I see a patient that's referred for consideration for left atrial appendage occlusion as an alternative to anticoagulation, my first act, or the act of the nurse practitioner that's seeing the patient, is to calculate a CHA2DS2-VASc score. And that is a score which basically adds risks that we know raise the risk of an ischemic event or systemic embolization, including congestive heart failure, hypertension, age over 75 with a weighting of 2 for that, diabetes, prior stroke, vascular disease, and age between 65 and 74, and female status. So this allows you then to rank people in a range that would be treatable or not treatable, eligible for anticoagulation or not, with 2 being the threshold to initiate an oral anticoagulant. Similarly, I will tell you that I also immediately go to the app to calculate HAS-BLED. I'm not doing that in my head. And these, again, are broadly available for everyone to download. And this is another simple ranking procedure which adds together risks associated with hypertension, abnormal renal or liver function, stroke, major bleeding history or bleeding disposition, difficult to control INRs, age over 65, antiplatelet use, or perceived excessive alcohol use, and come up with a score which basically indicates to you the annual major bleeding risk for that patient. The devices, which we'll talk about, all have thresholds for CHA2DS2-VASc, not HAS-BLED, but for CHA2DS2-VASc for being eligible. And again, 2 being the eligibility threshold in general for an oral anticoagulant. And it's a really powerful thing for us then to be able to advise patients based on a more quantitative measure of what we think their risk per year of a major ischemic event would be.
Very good. So we're trying to prevent a stroke. We've talked about warfarin and the data. We've talked about the NOAC or these new oral anticoagulants. Mostly, what we use a lot is with apixaban or Eliquis, the advantages, the stroke prevention, but the problem with bleeding, problem with adherence, and problem with lowering the dose. So we still have these patients, and we want to prevent a stroke. We don't want them to bleed. We know that about 90% of the blood clots that cause a stroke are localized inside the left atrial appendage. And it's a small portion. Maybe you could explain to us, a little bit, Greg, what is the left atrial appendage? But so could we avoid really all the systemic complication by using more of a local approach? And, by putting a device there, you would have 100% adherence. I mean, it seems like the winning solution for our patients. So tell us a little bit, number one, who should we consider, a Watchman device or an atrial closure device? And then maybe you could describe to us a little bit about this atrial appendage and maybe discuss the device itself.
Sure. So who is actually a candidate for left atrial appendage occlusion is an evolving discussion. And I think as the device has become more broadly applied and skill and complication rates, as we'll talk about, have progressively decreased, the broadening of eligibility in terms of who meets criteria is reasonable. Now, there are very specific CMS criteria for who is a candidate for it. It has to be someone that is eligible for short-term anticoagulation, but we feel is not appropriate for long-term anticoagulation. Interestingly, in the 2 large randomized trials for the device, Protect AF and Prevail, the patient had to be really eligible for really long-term anticoagulation, and this was being studied as purely as an alternative to warfarin. But in practice, when approved, it was really approved for, again, someone that could be perceived as being tolerant of short-term anticoagulation, 45 days, versus a long-term anticoagulation, and had a CHA2DS2-VASc score of 3 or greater. And that opens up this big interpretation of who is able to tolerate short-term anticoagulation but can't tolerate long-term anticoagulation. When we first started putting this device in, we were in the mindset that really this had to be patients that were completely intolerant of anticoagulation, repetitive GI bleeding, hematuria that was relentless, epistaxis, subdural hematoma, history of hemorrhagic stroke, really a group of people that weren't studied in the initial trials for the device, and are probably the most difficult people to enroll or to actually use the device on, because you have to nurse them through the 45 days of anticoagulation that's required after implantation. And it's important, I think, for everyone to realize that the approval for the 2.5 device, which we'll talk about in a minute, which was the old Watchman device, was really required warfarin as the 45-day management strategy after implantation. Now that's changed with Flex, and we're now allowed to use NOACs. But the concept of using warfarin in order to be in compliance with FDA and CMS requirements made it very challenging to treat the patients that were being referred to us initially for this device, which in everyone's mind was the patient that had repetitive GI bleeding, et cetera. So a challenging group. Now, as we have gone forward, as I've said, our interpretation of that requirement, can tolerate short-term but not long-term anticoagulation, has broadened to much different populations of patients. Elderly patients that are at risk for falls or have had significant falls, and therefore are at risk for significant bleeding complications. Individuals that are in employment that puts them at particular risk. And I don't want to be funny about this, but take an acrobat or someone that walked the high wire, or a mountain climber, or a motorcycle racer, or even a butcher. These would be people that you could consider being at increased risk long-term for complications related to anticoagulation, and therefore might be a good candidate for a device that would not require that. And in a more practical sense, we know that, for example, the end-stage renal disease population who are on hemodialysis are at particularly increased risk for bleeding complications long-term, systemic bleeding complications that would be life-threatening. And that population of patients is now being looked at more and more as an ideal group of people to leverage this technology in, so that we can reduce their ischemic stroke and systemic embolization risk with a device and not require them to be exposed to bleeding. So again, our interpretation of who is a candidate is broadening appropriately, I think. And we're not simply restricting this to people that are at exceptionally high risk for bleeding, such as the GI bleeding population. The appendage itself is a remarkable structure, clearly with physiologic effects to it, but we know that it can be amputated without any major long-term complications for a patient. And that has led then to, I don't want to say a disregard for its importance, but for an understanding that we can manipulate it and change it without really altering a patient's long-term outcome just based on the presence or absence of their appendage. And so, exclusion of the appendage early surgically was explored and has its own evolution. And you might talk about that in your next podcast, as you were discussing. And this has led us to then come up with ways to plug it, because we know from a variety of really observational studies, both autopsy studies and transesophageal echocardiographic studies, that have shown that in patients that have had major ischemic events, either systemic embolization or stroke, that the left atrial appendage has been significantly represented as a source of those emboli. And so that led, along with the challenges of using oral anticoagulations for prevention, to this original interest in developing a device, which has in itself an amazing history.
Can you describe a little bit the Watchman device, not the newer version, but what was,
Yeah.
placed.
So the Watchman device, and I'll encourage all the listeners to really kind of explore this if they haven't already and aren't already very experienced with it. On the internet, there's lots of representations of it. But the device was conceived of as almost a cork, if you will, that would plug the appendage and prevent the formation of thrombi there that would then be embolized. And it is it's gone through several iterations, but the 2.5 device, as they refer to it, the one that was approved following Prevail, is a nitinol frame. It looks much like a parachute. It has a PET fabric that covers the crown of the device. And beneath that are some extended feet, if you will, with an open frame at its base and a series of 10 anchors that are attached to these self-expanding feet that allow it to adhere to the appendage tissue. And the concept is that in a compressed form, much like a compressed self-expanding stent, this is delivered into the appendage, positioned in a way that we can talk about shortly, and released, closing off the appendage with the outward force of nitinol and with the anchors that we described and the PET covering, which then allows for immediate prevention of emboli of thrombi that might form behind the device, but long-term acts as a frame for the endothelialization of the device and its eventual incorporation into the left atrial wall.
So let's say I'm a patient and I was referred to you to get a Watchman device. What would you do? Is there kind of a pre-procedural kind of a imaging kind of protocol that I would have to kind of go to? And then if you could walk me through the procedure, once I have that's done, what is the process getting me admitted to the hospital, bring to the cath lab and so forth?
Great question. As part of the CMS FDA approval, a couple other important things are required for a patient to become a candidate for this, and that is includes something called shared decision making. And shared decision making is where a non-implanting physician, and that can be any non-implanting physician, a cardiologist, a neurologist, a primary care physician, has reviewed the patient's history, feel that they are not a good candidate for long-term anticoagulation, but perhaps are a decent candidate for a mechanical solution, and then are referred to an implanting physician for a second opinion. And so we see patients as a second opinion, as a consultation. As an implanter, I will see that patient, and I will really talk to them about all of these issues that we've been discussing, the challenges of anticoagulation, and the risks and benefits of having an alternative to that, which include this Watchman device. Part of the decision-making related to the original device led to a screening of the patient's left atrial appendage morphology. And that was done in two primary ways, either with transesophageal echocardiography or with CT scan. And that allowed us to characterize the appendage, exclude the presence of thrombi, which would require us to extend anticoagulation for a period of time before a reassessment, and also to measure that appendage so that we could have a sense as to whether we had a Watchman device that would be able to exclude it. And the original device, and this is from memory, but I believe could exclude appendages that were roughly in the 17 millimeter diameter up to 30 millimeter diameter. And if they anatomically met those requirements, were a decent candidate for short-term anticoagulation, and had shared decision-making with their referring physician, then we would offer them the opportunity to participate in the procedure. The procedure itself involves the patient presenting in the morning, having an anesthesiologist evaluate them, because general anesthesia in general, though there's a potential for this to change in the future, now is standard of care. The anesthesiologist would evaluate, and the patient would then be brought to the catheterization laboratory. General anesthesia with endotracheal intubation would be instituted. A transesophageal echocardiographic probe would be placed to allow real-time monitoring of the appendage during implantation. And then access and placement of the device would be performed. And I can talk about that in greater detail if you'd like. Following that, the patient would be extubated. The equipment that was used to deliver the device would be removed from the venous system, and the patient would be recovered, observed overnight, and have an echocardiogram performed the next morning to exclude any untoward events from the procedure, primarily pericardial effusion. And the patient would then be discharged with a plan for follow-up. Now, this is all in evolution also now with the advent of the Watchman Flex device, which has demonstrated, I think, both in trial form in the Pinnacle Flex trial, but also in clinical application, much greater safety in its deployment.
And we'll talk about that, a little
Sure.
bit later. So, and then if you could tell us a little bit, Greg, about the post-procedure protocol. I mean, obviously,
Yes.
the patients are, still having to take warfarin for a little while. If you could tell us more about that.
Absolutely. So again, by CMS FDA requirement with the 2.5 device, the original Watchman device, a period of anticoagulation for 45 days was advised following the implantation using warfarin and an 81 milligram aspirin. At the end of the 45 days, the patient would return for another transesophageal echocardiogram to evaluate the device for several important characteristics. Most importantly, was the appendage completely excluded, or was there a leak around it? If there was a leak, was it less than 5 millimeters or greater than 5 millimeters? And was there any thrombus on the device? If neither of those issues were clinically important at the time, then the anticoagulant warfarin would be discontinued, and the patient would be transitioned to clopidogrel, Plavix, 75 milligrams a day, along with aspirin. And this would be then continued for 4.5 months to complete a 6-month period of anticoagulation, if you will, at which time a clinical evaluation would be performed. And if the patient was doing well, the clopidogrel would be discontinued and they would be transitioned to a 300 to 325 milligram aspirin daily to continue indefinitely, with the plans for transesophageal echocardiography by registry requirements at a year and at 2 years thereafter, again looking for issues related to the device.
So let's talk about results. I mean, we've had, thousands of patients that have been studied and enrolled in this trial. We had Protect AF, we had Prevail. If you could give us an idea of what is the pooled data, using, Watchman, what was the risk of, stroke, death, and emboli versus warfarin? What was the bleed versus warfarin? If you could give us maybe a little summary of.
Sure.
Data.
So, the trial data now on Watchman is prolific and includes the 2 major randomized trials, Protect AF and Prevail, the 2 continuing access registries, which sort of flanked those 2 large randomized trials, and then a series of data afterwards, including a large European registry called Evolution and the large U.S. Registry, which now has, I think, over 40,000 patients in it that have been reviewed. Again, importantly, everyone that participates in a Watchman program will participate in a registry as part of the CMS requirement. So that data is actively accumulated and reviewed. So one of the most important things when we talk about this with patients is what are the risks of the procedure? And that's been such a fascinating thing to follow with the clinical trials, because it's shown as experience by operators and evolution of the procedure has occurred, not to mention the change in the device from 2.5 to the current flex device. The risk of procedures has dramatically dropped as well. So when we look at Protect AF, one of the big reasons that the FDA required additional data was because of this incidence of pericardial effusion and tamponade that was just over 4%. And so it was hard to really feel fully excited about the device in terms of its reduction of stroke to a level that was comparable or at least non-inferior to warfarin when we were faced with this large complication rate within the first 7 days. But as we've watched these trials progress over time, that rate of pericardial effusion, which we all think of as being such a major marker of complication for this procedure, has dropped from that over 4% rate down to 1 or less with the newest device, and probably just around 1% if you look at the large pooled cohort of US cases. And similarly, all of the other complications that we think of as being very severe associated with this, procedure-related stroke, which often I should note is related to air embolization, especially early on in the trials in Protect AF, device embolization, and then procedure-related death. All of these risks have dropped well below 1% and below 0.5%. So that now with the Pinnacle Flex data, which represents the newest iteration device, the overall risk of a major complication is 0.5%. So a big dramatic change. Efficacy has steadily increased. And by efficacy, I mean a successful implant that has no significant peri-device leak has gone from probably right around 90 to 91% with Protect AF, way up to 98% or higher with the Pinnacle data, which is the Watchman Flex device data. So again, improvements in the procedure, changes in the device, and implanter experience have all contributed to this amazing change in success of an implant and reduction of risks.
So overall, if we pull the data, we can see that, you know, the stroke, death, and emboli with the Watchman device has been around maybe 2.5 to 2.8% versus warfarin, which is 3.4%. So it basically met the criteria for non-inferior. If you look at the bleeds, they've gone from 1.5% with Watchman, and we know with warfarin it's still around 3.5, 3.6%. So obviously there was decreased mortality, which was very important. And it looks like it was primarily due to decrease in hemorrhagic stroke, you know, that was, you know, present in warfarin. Yet if you look at all the stroke, the ischemic stroke without hemorrhage was a bit higher in the Watchman. And it's really tried, you know, it's kind of interesting academically to kind of see, you know, why that is. I mean, obviously the Watchman is not going to treat everything, but it makes you wonder, you did have some complication of thrombus, related event or onto the device. Actually, this call it, you know, the DRTs or the device, you know, related thrombus that was not that frequent, but it was about maybe 3.5% or so of these patients. About 25% get a stroke, and it makes you kind of wonder, you know, maybe with the new design, and we'll talk in a little bit about this with the Flex device, that hopefully we can really eliminate, you know, this problem of device-related thrombus. Maybe it will, you know, go away. If you could explain to us what's happening with the Watchman device, why is there a thrombus that is occurring there? That is
great question. This is a very real thing that we do see, and I think any operator that is honest and doing enough procedures and doing surveillance, importantly, has seen this. If we don't surveil, we don't see it. If we don't follow up, we don't see it. So surveillance is the key. And I will give great credit to my partner, Dr. Mustafa Ahmed, who, when designing the framework of our program, really has insisted on very consistent and obsessive follow-up of the patients at both a year and 2 years with transesophageal echocardiography. And so we see in a small percentage, but a real percentage, again, somewhere in probably the 2 to 4% range, an episode of device-related thrombus. And we think that this may be related to delayed endothelialization, but it also could be related to a varying milieu in the left atrium for specific patients, so that individuals may have greater stasis, though truly having non-valvular AFib, the relative stasis in an atrium may be greater in one individual than another. And as a result of that, they may have a more prothrombotic milieu and be at greater risk. We don't have a way to risk stratify those patients beyond identifying them as non-valvular AFib, but it is a fascinating question in the future whether we will actually have better ways to look for atrial myopathy or some type of a milieu that would encourage it. Early device-related thrombus formation is thought to be, again, delayed endothelialization. So there is a protocol for extending anticoagulation if it's identified. If we identify it at 45 days, anticoagulation is prolonged. And following a prolongation of for approximately 3 months, following that, we then restart the whole protocol of transition to DAPT and then reset the follow-up protocol as far as transesophageal echocardiography goes. But I think your point is well taken. It is uncommon. It is increasingly uncommon with the Flex device, at least with the preliminary data from that. But I will say for both the 2.5 device and with the Amulet device, it's sort of a floor somewhere in the, 3 to 3.5% range. It is an issue that we're going to continue to deal with. And again, some design changes with Flex may have impacted it, and we can talk about that if you'd like.
These are very good points, Greg. We know that not all strokes are embolic. Even in patients with AFib, up to 25% can have intracerebral, process atherosclerosis that can cause a stroke. And I think this very important factor that, particularly in patients that have high CHA2DS2-VASc score, that are very much a setting for prothrombotic, procoagulants, patients with severe heart failure, as well as atherosclerosis, really increased risk of stroke, as a patient population. So this milieu, I think, is a very important role. And certainly a local treatment like a Watchman is not going to be the solution for these patients. It's going to be important to try to sort out who are these patients, how can we identify them and classify them, identify and treat them, appropriately. So we've talked about, warfarin a lot. I mean, you've mentioned a lot of the use of DOACs or the newer oral anticoagulants with the Watchman. There was some, studies actually that really kind of compare warfarin with the NOACs, having Eliquis primarily after the Watchman implantation. It looks like there's really no difference. I mean, there was like the bleed were about the same compared to Coumadin. The stroke was about the same compared, to Coumadin. And it looks like the treatment of warfarin slowly is really kind of going away, and maybe, that would be a good thing for the patient since there's so much, problem with the use of warfarin.
And I know that you'll be exploring this in the second part of this podcast, but it's important to note that the Europeans have really moved way ahead in terms of their use of off-label anticoagulation strategies, and that has and have looked at that in their large registries, and they have appeared to be safe and effective. But that has also led in this country on an as-needed basis, continuing a NOAC during that 45 days of anticoagulation post-implantation in place of warfarin, or in fact using dual antiplatelet therapy. on an as-needed basis as the physician perceives a benefit for the patient, a reduction in risk perhaps, improvement in compliance, and I believe documents it appropriately as being off-label, but clinically appropriate under the circumstances. A patient, for example, with bleeding issues who has been successfully maintained on a DOAC, why would we transfer those people to warfarin with the data that we know exists in registries showing efficacy and safety of that as a post-implantation regimen? And similarly with DAPT, we know that there's increasing data suggesting that that is beneficial as a post-implantation strategy. If someone is on that, or if we perceive that they are at really high risk for bleeding related to warfarin or a NOAC, why would we not use that? As long as we document it, I think that that's appropriate.
Well, this is perfect, Greg. Let's move to Europe, and let's move to Czechoslovakia and move to Prague in particular. I mean, one has to wonder, how does the Watchman really compare to the NOAC or those compared to Eliquis? So there's the Prague 17, and maybe you could kind of introduce or tell us a little bit more. Not only they use the Watchman, but they use also the amulet or an Implantable, which is another device to kind of close that. So we got a lot to talk about. Let's talk about, first of all, how does the amulet, compare to the Watchman? And then second, what did the study show? How did, these devices compare to the newer anticoagulants?
Sure. Well, the amulet is a Implantable device. Its full name is Implantable amulet, and was designed again for left atrial appendage occlusion, and has a design that's very unique compared to the Watchman. So it is very similar to other Implantable devices. It has a foundational lobe, if you will, that fills the neck of the appendage and is sized for that neck. It then has a connector or waist between that and an external disc, which actually excludes the ostium. So if you can imagine this, it looks like a frisbee sitting on top of basically a slinky, and that slinky fills the waist of the left atrial appendage, and then the disc firmly comes down on top, almost like the top of a pot, covering it and excluding it. And that device has a variety of anchors as well on the lobe, which fills the neck of the appendage, and then endothelialization is expected to, in a similar manner with the Watchman device, eventually incorporated into the left atrium. So it has been looked at and is on the verge of approval in the United States. It's available in Europe. It was looked at in the Prague 17 trial that you're referring to, which was a multi-center, 10-center, I think, study in Czechoslovakia, where either the amulet or Watchman was used at the implanter's discretion, and then randomized versus NOAC. Interestingly, in this trial, the anticoagulation regimen for the device was dual antiplatelet therapy. And so we really had really important source of data confirming the safety of an anticoagulation regimen post-implantation using DAPT versus ongoing management with NOAC. And the trial did demonstrate, there was a composite endpoint for this, including stroke, TIA, cardiovascular-related death, bleeding, and procedure or device-related complications. And they were able to demonstrate non-inferiority at a median time point of about 20 months. It was not a gigantic trial, but it was randomized, and about 200 people in both arms. I think is enormously important as we look to the future of how we're going to manage patients with anticoagulation post-implantation and importantly, on the power of this device to also compete with DOACs as opposed to warfarin for our patients that need to be treated.
Yeah, great results. I mean, primary events with the atrial closure device, by the way, I think 60% were amulet, and they had 40% that was Watchman. There may have been even few Watchman Flex in there, but 11% primary event versus 13.4 with the DOACs, which we consider. I mean, you look at the newer, and it was about 96% apixaban or Eliquis. So this is one of the best. We know that the Eliquis and Xarelto and Pradaxa, they're about 20% superior to Coumadin. And now we're comparing to the best medical therapy that we have, and we're having, results that are non-inferior. So, I think it's really exciting. And it really kind of brings us, back to what we want to do here. And it's the Champion AF that we're going to start moving. As a matter of fact, I think you started already enrolling. Did you want to tell us a little bit about the new Watchman device, so-called the Watchman Flex? What kind of differentiates it, from, the old Watchman? What does the new one, have? Why is it safer? And, and then you could tell us a little bit about the trial.
Sure. So this has been a sea change in terms of the device design over the original Watchman 2.5 device. I think all the implanters that I've spoken with really have sensed the change and are really feeling confident about its use. So as opposed to having an open design on the LAA side, like the 2.5 device did, which had open nitinol feet, if you will, that were quite pointy, this device is closed on that end. So it forms something that is referred to as a flex ball, which is quite soft and allows for its manipulation in the appendage with a much greater safety margin than the older device. It has a couple other features which improve its closure of the appendage. It has 18 points of contact instead of the original 10, and it has 2 rows of anchors as opposed to a single row of anchor. It has fabric that covers more than 2/3 of its length, if you will, or depth, I should say, into the appendage, which allows it to have greater potential for closure as it presses up against the left atrial appendage wall. And finally, it has a recessed screw insert to which the delivery cable is attached to, as opposed to a protruding one, which is felt to be advantageous for encouraging endothelialization and decreasing device-related thrombus. In fact, the rate of DRT in the Pinnacle Flex trial was about 1.8%, which was the lowest observed of any of the trials to date, including those with amulet. So a very unique design, and one that allows us to capture and release multiple times so that we can optimize its position in the left atrial appendage. Though we could do that to a certain extent with the 2.5 device, the challenges of its deployment and the risks associated with repetitive deployments led us to be much more cautious about that. And as a result, I think we had more limitation in its utility. So that now, when we look at an appendage, and I guess this is a good way to describe how safe we feel it is now. When we look at an appendage, we aren't struck by how challenging it's going to be to close based on its varying appearance. And remember, appendages are as varied as one's fingerprint is and have shapes that range from what's referred to as a seahorse to a crab claw to a chicken wing. And depending on the type of that appendage, we would often be struck with what was going to be a challenging deployment with the original device. With the new device, we don't really feel challenged to the same extent. It requires much less depth for its deployment. It covers a larger range of ostial sizes, going from 15 to 31 millimeters now, roughly. And so you had asked me offline about issues related to screening now for patients. And I'm in a place of change in terms of my decision on how I screen a new patient for Flex. And I feel I'm not as compelled to look at that patient with either CT or TE ahead of time, because I know that the likelihood of closure with the Flex device is much, much more likely. And in fact, in the Pinnacle Flex trial, they reached a 100% success rate for their closure based on achieving no residual leaks of more than 4.9, if you will. Everything was less than 5 millimeters, which was considered the clinically important threshold. So this device was approved based on the relatively small non-randomized Pinnacle Flex trial, along with the constellation of other data that had been obtained for the 2.5 device. But the most exciting thing, I think, for this device, but for left atrial appendage occlusion in general, is the next generation of trials. And that will include what you had referred to as Champion AF, which is a Watchman Flex trial. But there will also be a trial looking at Amulet, I believe called Catalyst AF, which will be answering a similar question. And that is, can this device be deployed successfully in a lower risk population of patients, all comers, if you will, patients that do not have a contraindication to long-term anticoagulation, but simply have an indication for anticoagulation. A lower CHA2DS2-VASc threshold, 2 for men, 3 for women, instead of 3 across the board. No shared decision-making. Patient presents to you, you say, this patient should be implanted. I'm referring them for implantation, and they get implanted versus anticoagulation. And the anticoagulation regimen will be also very exciting, because though it will be encouraged to use a NOAC, any of the NOACs, dual antiplatelet therapy is also approved for the post-implantation regimen, which will be a 3-month period of anticoagulation, followed by transesophageal echocardiography at 4 months to assess for leak and for device-related thrombus. So really a big change. And this is the largest trial to date too. It will be 3,000 patients, and they will be followed for 5 years. So a big investment by the company that manufactures the Watchman device, a similarly big investment by the those behind the Amulet device, and really pushing this field into a really well adjudicated place from a scientific standpoint.
Really fabulous and very exciting. This is really kind of game changer. I mean, if you could really get rid of, anticoagulation long term, decreasing the problem of bleeding, decreasing this problem of adherence, cost, also really, really interesting. It would be interesting to see, what happens. And already, I think you started enrolling patients, haven't you?
Our site has been approved to start up, and so we're looking forward to that. And I think, again, just an amazing opportunity for patients that might have an interest in not being on anticoagulation long term.
Now, let me ask you, Greg, I know you're not an electrophysiologist, but, there is also this push, particularly in Europe, to look at putting a closure device after doing an AFib ablation. Do you think this will ever take off in the United States?
I think that it probably will. I think that it makes sense. It emulates the surgical approach to the treatment of atrial fibrillation, which is ablation surgically with then exclusion of the atrial appendage. So I think that a comprehensive approach makes sense intellectually. It will be interesting also to see whether there's some benefits to excluding the appendage in terms of electrical treatment for atrial fibrillation. Again, not my area of expertise, and I don't want to wade too far into it because I'll probably get caught in the weeds. But I think that it, from a clinical standpoint, makes sense to me. If you're already in the atrium and you are treating that patient for atrial fibrillation and you've already absorbed the risk, if you will, of left atrial appendage access by performing the transseptal puncture that's required for the procedure, it makes sense to use a demonstrated treatment for exclusion of the appendage and reduction of the patient's need for anticoagulation.
Well, we certainly will discuss that a little bit more with our next podcast with an electrophysiologist who does a lot of atrial fibrillation and get his take, whether something like this could take off in the States. So non-valvular AFib and stroke prevention, possibly the Watchman Flex device and possibly also the amulet could eliminate the need for long-term anticoagulation. I think it's a possibility. It's somewhere in the future, in the next few years, we'll have to see what the data, kind of shows us and where science leads us. Greg von Meering, thank you very much for being here today for this great podcast.
Really enjoyed it. Thanks for the opportunity.
Thank you.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.